Dear colleagues, I really feel honored to be invited to have this lecture in this particular session of Pearls of Wisdom, and the title I chose is The Noah Conundrum, How to Successfully Get Out of a Maze of Problems. I declare no conflicts of interest. I will begin this lecture by sharing significant milestones in my professional life. Part 1 is about the key achievements in andrology and assisted reproductive techniques. In '82 at Magenta Hospital, Milan, I successfully retrieved motile sperm post-ejaculation from an artificial spermatocyst inserted into the vas deferens in a post-tubercular obstructive azoospermia patient. And in '83, these were utilized at the Locarno IVF Center, one of the leading Swiss IVF facilities at that time, where I worked as a scientific worker, resulting in an embryo formation and a biochemical pregnancy. From '88 to '91 at Como Hospital, I performed microsurgical vasovasostomies and epididymal vasostomy in cases of obstructive azoospermia. And this surgery led to a few spontaneous pregnancies in the vasovasostomy cases, and in some instances, the recovery of motile sperm in semen following epididymal vasostomy. This is my case series. And in one notable case, the poorly motile sperm were used at a renowned IVF center in Rome, resulting in a pregnancy that tragically ended in the 4th month due to a severe abdominal trauma from a car accident. In '91, I pioneered a groundbreaking method of sperm recovery via seminal tract washout in a spinal cord injury patient with untreatable anejaculation. And this innovative approach led to successful IVF treatment, again at the Locarno IVF Center, resulting in a full-term pregnancy, the first baby born globally using this procedure. From 1995 to '98, as a head of the Andrology unit at the San Paolo Hospital in Milan, I regularly performed TSA on patients with obstructive azoospermia and non-obstructive azoospermia. The recovered sperm were cryopreserved in the semen bank of the Andrology unit. However, due to the lack of ICSI capabilities at the hospital gynecology clinic, which only offered conventional IVF, couples were compelled to transport cryopreserved samples to external ICSI centers chosen by them. In '98, following my meeting with Professor Schlegel, I initiated microtesy procedures for NOAH patients cryopreserving retrieved sperm. However, challenges arose when external ICSI centers deemed the samples unusable due to immotile sperm content. And these setbacks risked my professional reputation, compounded by the gynecology clinic's refusal to implement ICSI technology under these circumstances I resigned. The general manager authorized an independent ICSI laboratory within my andrology unit, making San Paolo the only hospital in Italy with dual embryo labs, one for the conventional IVF in the gynecology clinic and one for ICSI in the andrology unit. Despite lasting internal conflicts with gynecologists, microtesy samples ultimately led to successful pregnancies and healthy newborns. In 2000, I identified that our biologists were not accustomed to conducting extended search for sperm in microtesy fragments, and I implemented longer search times up to 4 hours, which significantly improved our sperm retrieval rates. In 2006, due to excellent delivery rate resulting from microtesy activity, San Paolo Hospital established the Department of Urandrology and IVF, appointing me as its director. This department became the only IVF center within the Italian National Health Service led by an andrologist rather than a gynecologist, which is very scandalous. From 2006 and 2013, I focused on refining the microtesy technique and enhancing biological procedures for sperm retrieval and cryopreservation. During this period, I trained a biologist who has been working alongside me in the operating room for over 12 years. Our center began attracting NOA patients from across Italy and abroad. In 2014, I transitioned from San Paolo Hospital to join an IVF center in Lugano, where our sperm retrieval rate further improved. However, I found the pregnancy rate unsatisfactory, largely due to the gynecologist and embryologist being accustomed to managing routine infertility cases and undervaluing my microsurgical work. In 2015, in response, I established a new art center in Paderno Dugnano, close to Milan, enlisting two of my former embryologists from San Paolo Hospital. And from 16 to 20, sperm retrieved by microtese and cryopreserved in Lugano were used for ICSI in Paderno, yielding favorable outcomes. In 2020, following a change in the management of Procrea Lugano, I was appointed scientific director of the Art Center. Some gynecologists and embryologists were replaced, and my work on NOA was highly valued, leading to excellent results. Meanwhile, my senior biologist further advanced the biological procedures associated with microtese. Additionally, I developed the fresh microtese for ICSI procedure, which has remained our preferred method for the past 4 years. And in fact, I presented in Athens very recently a lecture on the fresh microtese for ICSI procedures. Conclusion of the first part. I may have burdened you with my personal story, but I firmly believe it offers valuable insights. Why? Because the pinnacle of andrological work in fertility lies in the microsurgical management of non-obstructive azoospermia. My journey illustrates that achieving outstanding results requires more than technical skill alone. So the key lessons are, first, microsurgical skill alone is not sufficient. A high sperm retrieval rate is meaningless unless the sperm are utilized effectively to achieve pregnancy. Second, full collaboration with specially trained biologists and gynecologists is essential. They must recognize and support the importance of your work. Third, this collaboration cannot be assumed. Western gynecologists in particular often discourage non-obstructive azoospermia couples with pessimistic sperm retrieval rate and clinical pregnancy rate information to gain consent for donor sperm use. Some of them even attempt surgical sperm retrievals like TEFNA, leading to poor results and the apparent necessity of donor sperm. Fourth, control over the biological and gynecological management of your couples is non-negotiable. You are ultimately accountable for the outcomes, and your professional reputation is always at stake. Fifth, biologists with expertise in sperm search from microtese fragments are indispensable. They must continuously update their knowledge and adapt procedures based on the quantity of sperm found in tissue samples. The second part of my lecture will be about a reflection from 30 years of experience in testicular sperm recovery. Fine needle aspiration remains relevant in case of obstructive azoospermia, particularly when fresh ICSI is possible. However, sperm recovery is typically limited, and there is a significant risk of discovering dead sperm after freezing and thawing. The technique can be repeated if necessary. In NOA, fine needle aspiration orthese is entirely inappropriate. It is unreliable both as a surgical recovery method removed from the EAU guidelines in 2008 and as a diagnostic pre-surgery tool. Over the years, I have witnessed many successful recoveries via microtese in patients previously submitted to fine needle aspiration orthese and diagnosed with sertoli cell-only syndrome or suspected tubular diagnosis leading to live birth. So the EAU guidelines in 2023 and 25 report that TSA is no longer recommended in men with NOA, and they should not be considered as a treatment of choice in patients with NOA. Multiple fine needle aspiration attempts are equally unreliable and can cause severe damage to testicular parenchyma. Animal studies and my personal observation during microthese surgeries have confirmed this damage. The more punctures performed, the higher the likelihood of bleeding, which can progress to intratesticular fibrosis. Practitioners of fine needle aspiration tend to operate under the motto, out of sight, out of mind. This is a NOAH patient. You can see the figure on the right, submitted into 10 fine needle aspiration each testis, and parenchyma results made of hyalinotic lobules with abundant fibrotic tissue and areas probably due to small hematomas. Seminiferous tubules are actually undetectable everywhere, except for few intact ones at the lower pole of each testis. Histology reports rare, involuted, and hyalinized seminiferous tubules with Leydig cell proliferation. Compound mapping may exacerbate damage. Although I have never encountered a patient subjected to it, I suspect most who undergo it never seek andrological care again. This is a residual, these figures report residual lesion in the testicular parenchyma after a single TSA, testis sonography 5 months later. So you can see by the arrow the lesion provoked by the needle pass, and also the area, the hypoechoic areas just closer to its borders. And the question is, what the results following many needle passes? In the past, conventional TSA was included in EU guidelines because the majority of urologists lacked expertise in microsurgery. Diplomatically, the guidelines recommended the conventional TSA for NOAH patients, but suggested micro TSA for more complex cases. Yet, is any NOAH case truly non-complex? A systematic review by Corona claimed no significant difference in sperm retrieval rates between conventional TSA and micro TSA, but this paper was deeply flawed. A subsequent analysis demonstrated significant differences, particularly in sertoli cell-only syndrome NOAH cases. Nevertheless, this rebuttal received limited attention. It is the letter to the editor by Esteves and the co-workers. So we can conclude micro-TSA is significantly more effective than conventional TSA in NOAH. Even multiple conventional TSA may achieve higher sperm retrieval rates than single conventional TSA. It must be emphasized that this procedure is more destructive, particularly for NOAH patients with small testicles, posing increased risks of bleeding and testosterone depletion. Actually, the EU 23 guidelines now recommend micro-TSA as the treatment of choice for sperm retrieval in NOAH cases. In 25 this year, GAF guidelines further emphasize micro-TSA as the preferred and most efficient procedure with stronger sperm retrieval rates compared to TSA and the conventional TSA. Micro-TSA remains the gold standard, and I hope more reproductive urologists capable of performing micro-TSA under optimal conditions will emerge to uphold this standard. So, essential for micro-TSA success: properly inform the couple about expected outcomes. Ensure thorough patient preparation for surgical recovery. Utilize an operative microscope with 18 to 40 per magnification. Techniques relying on lower magnification, e.g. loops, yield inferior results. I wish I no longer had to read papers like this one, preliminary results of microsurgical sperm retrieval in azoospermic patients, randomized controlled trials comparing operating microscope versus surgical loops, which shamelessly claims A. Micro-TSA performed with the loops at 3.5 to 5 per magnification. B. The equivalence of loops micro-TSA results to those of trifocal TSA. C. A sperm retrieval rate of 22%, a disturbingly low outcome comparable to that of fine needle aspiration, thereby effectively legitimizing malpractice. The average diameter of a seminiferous tubule with the preserved spermatogenesis is 180 to 200 microns. A difference of about 10 to 20 microns, more or less, can make a difference. How can one expect to discern these diameter differences at 3.5 to 5 magnifications? Employ biologists with expertise in sperm retrieval from testicular microfragments, sperm selection, and preparation for ICSI or cryopreservation. Collaborate with an ICSI center experienced in utilizing recovered sperm, whether fresh or frozen. Misjudgment in sperm usability can hinder progress unnecessarily. I sincerely hope to stop encountering reports, unfortunately a weekly occurrence, that state rare non-preservable spermatozoa were served, or rare unusable spermatozoa were found. This is a photograph of a report of a very important institution in Lombardy. Okay, you see a sample not useful for cryopreservation. Okay, but they found sperms. The higher is your microthese sperm retrieval rate, the more frequent will be your poor sperm recoveries, about 1/3 in our experience. Specific devices to preserve rare sperm are available. In any case, fresh rare sperm, if handled correctly, can achieve good fertilization and blastulation rates, as confirmed by our experience. If by not usable we mean that they have acrosome defects or are slightly malformed, Schlegel demonstrated that no specific defect, including the use of non-motile testicular sperm, fully precluded a chance of clinical pregnancy, albeit with a low fertilization rate and clinical pregnancy rate, but resulting in normal offspring. Our own experience has also confirmed this finding. The last part of my presentation will be a final reminder on medical ethics. We live in an era dominated by marketing-driven healthcare, where the quantity of services matters more than patient outcomes. Many IVF centers prioritize cost efficiency to benefit owners, often at the expense of patients. As medical professionals, we must monitor or reject this approach. We are not salespeople, we are doctors committed to ethical practice. In many states, doctors recite the ancient or modern Hippocratic oath immediately upon receiving their degrees, solemnly pledging to uphold its principle throughout their professional lives. A similar oath exists also in India, the Charak Shapat, or physician's pledge. In Islamic countries, an oath of a Muslim physician according to the ethical teaching in the Quran. So, when counseling a NOA infertile couple, offer detailed, empathetic information. They are entrusting you with their own one and only chance to have a child genetically related to both of them. Prioritize careful preparation over rushing into surgical intervention. Always use the best retrieval technique, microthese, performed at a qualified IVF center capable of handling sperm optimally. Never justify offering less effective option like a conventional these due to cost concerns. If a member of your family, a loved one, were gravely ill, would you choose a less effective treatment solely because it is cheaper instead of the best care despite its cost? Keep in mind that no patient perceives their condition as a serious illness, deserving of the best treatment. On the topic of cost, I recall a striking statement made by a reproductive gynecologist regarding the expenses of an IVF cycle. This couple is pursuing a child. If we perform our work effectively, the cost to success probability ratio is less than the price of a medium-sized car. Moreover, while a car lasts 10 to 20 years, a child is a lifetime gift. This statement is now essentially true when a couple accepts a microthese with ICSI and the use of donor sperm in case of the negative sperm retrieval. This statement underscores the importance for couples with NOA of investing in proper sperm retrieval. A positive sperm retrieval is the key to achieving successful outcomes. When working with an excellent IVF center and enough MetaFirst 2 oocytes, the cumulative delivery rate can approach 55% or more. Conclusions. Throughout my career, despite adhering to guidelines, I have faced moments of uncertainty regarding the best course of action. In such cases, I always ask myself, if I were the patient, which solution would I choose? This guiding principle has never failed me. When in doubt, trust this method. You will never regret it, and your conscience will remain clear. Well, so thank you all for listening, and thanks to the GAF, the new School of Athens of Andrology.
Thank you very much.